incarceration, and you mentioned police, and you mentioned lost time for a lot of people who are not really criminals, but are caught up in this illegalization of marijuana. So I think we should address it as one of the risks involved in this issue.
But that's a different question altogether, isn't it? That's legalization, and we're talking about medical.
But it isn't. But as doctors and as representatives of public health, it's an incredible public health hazard that many families who have had, people in the family that have been caught in the illegal part of it have suffered doubly. And it's not good and it's not right, and we should address that. Not take a stand necessarily, but say that it's one of the issues that's involved anytime you're talking about having to deal with this illegal.
In the state of Minnesota, if I'm not mistaken, 2.5 ounces is the cutoff point under which it's decriminalized.
Yeah, it's decriminalized.
So it's actually, you're talking about decriminalized misdemeanor offense versus medical marijuana. The quantity, if you're not going to get a felony unless you get a felony either way, despite the medical marijuana.
Question back in the corner. Did I see somebody add something? Nope. Okay, go on. Brett.
Question I have is, you've heard the information on the law now, and how do people feel as far as the restrictions about who can prescribe it and the guidelines of who gets it? And the reason I ask that is because about 15 years ago, we were all criticized because we were not being paid aggressively and held up. And now, 15 years later, I got an office full of people that are huge problems and stuff. And I'm just concerned that, I understand the idea of empathy and these special cases and stuff, but is there a safeguard here that keeps the door where it is, or does it continue to widen and more and more people get it? Because I can say right now, the people that you listed up there, the people that will be in my office asking for it, will be the back pain people and always have pain. I'm asking, now what do I do? And so how do you folks feel about the way the law is written, part of, safeguarding that and controlling it in some way in the future? Because we got the issue that seems is a double jeopardy. One is, yes, you would like to have help the people that maybe would be the last thing that they could use. But at the same time, you've got this huge problem out there that once you're at the door, how do you keep it only that far?
And I would respond, I don't think you can. When you look at the states and how the bills are worded in your states and for what conditions, as it is here in Minnesota, these are the conditions, but then there's all these other category, and that's not the individuals that are coming and seeking the certificate for medical marijuana. It is the back pain, it is the anxiety, it is all those other conditions. I don't know any way that you could be able to actually stop that or close the door.
Hep C is problematic. People with Hep C, that's an enriched population of addiction, and Hep C is often asymptomatic. Go chronically for many years. It's often subtle symptoms. That's a problematic diagnosis.
So again, I want to be respectful of time. We were planning to get over about 8, but I'm going to go till about 5 to 10 after, and then if the panel can stay later to ask questions. I do have some wrap-up questions we need to ask, so I'm going to take about 5 more minutes of questions, and then we're going to go. And there was somebody over here. Okay, go ahead.
Yeah, I think that I really appreciate that you're having this forum. I'm the current president of the Minnesota chapter of American Society of Addiction Medicine, and I would recommend that everyone, look at the public policy statement that ASAM's written. It's very well referenced and thought out, and I think it makes some good points, as Dr. Specker already said, and it's out there on the website, at ASAM's website. I think there's an issue that I'd like to just touch on again, and that's that the bill puts the onus on doctors, right, to certify, this patient needs it. But as we've already heard here, and as we know, that, doctors don't feel like they've been trained or educated enough to make those decisions. So it's like the legislature is telling us, doctors, okay, we think you should give it, and now you figure it out, right? And it's all on the onus of the physicians.
Ask your doctor about it.
Yeah, ask your doctor. That's what it says. Right?
As a primary care doctor, I have no idea how I would make that decision, and it puts us in a very difficult position trying to do an exam and take a history and then say, I don't think you qualify.
Right.
You know, and,
Or what,
and-
how do
and
you
the
even
upfront-
determine if
the
somebody
upfront cost.
qualifies?
The upfront
That's
cost of
why,
that.
I mean, I think that's why we have the system of the FDA, right?
Right.
To screen drugs, to review all the evidence-based studies, to decide whether the risks outweigh the benefits, and that's where I think this should go. I mean, I think this shouldn't be a thing debated in our
And
legislature.
you're talking about changing from class 1 to class 2, possibly let the FDA do the work and have the restrictions based on the class 2.
Well, right. How, I mean, you know, that's what the whole system, I mean, that's how all of our other drugs are vetted, right? That's how we decide whether opiates benefit outweighs the risk, right? Because there's studies and because the FDA has looked at that. There are
Sometimes better than others.
There is evidence, well, I know, and the FDA is not perfect for sure, I understand. But there is evidence out there, and, you know, it's not ideal maybe, it's not complete, but at least it's a start, and that's where it seems like makes sense for me to start. You
You
know?
don't feel ready to comment.
Yeah, I'd like to. I mean, we are doctors, we have responsibility. And if I would not be qualified to make that judgment for sure, but there are other doctors who can. Like right now, there are doctors who do opioids, pain specialists, whatever. We should have the same kind of specialization. I don't see why we should, you know, go away from this responsibility.
But that's also...
Any other comments from the panelists about that?
I would agree in some respects too that as a physician, this is our duty, is to understand what it is we're prescribing our patients. That's a sacred responsibility, and that's what I engage in with my patients. Not knowing is not an acceptable answer to me, and I'm not saying that's what we're comfortable with. And I think there are parallels here, and I think the challenge that we're looking at is full plant use versus medical use, and the risk for abuse is present in there, but it's there with other medications too. Several people have brought up opioids. I mean, I don't need to throw stats at you, but 1 in 500 patients prescribed opioids for chronic non-cancer pain will die because I prescribed it. I mean, that's real. And I think NPR has been doing some posts lately on how the increasing trade of heroin, which is one of your natural derivatives of your oxycodone, of how that's the go-to drug after the oxy scripts run out, they go to heroin. I mean, that's all other social things that's on us as physicians as well. So, I mean, these things are out there, and we're obviously touching on these, and there's a lot of us, what we're talking about, social responsibility. Yes, that's true, that's there, we need that. But we also are looking at what are the benefits, what are the potential benefits. Again, I don't think full plant use is a good idea because I can't tell you what I'm giving anybody. But I also think we need to strongly come out, perhaps. But we need to really we're getting this declassification. We need to be able to, the cannabinoid system is there, it's real, it's present in our bodies. We should understand how this works.
You've been very patient. Yes.
I just want to share my perspective, and I really appreciated all the comments and people's reservations and good points about potential dark side and so forth. But I'm a primary care internist, and I work for 20 years. I've been doing this since residency, and I see the sickest of the sick. I'm not an oncologist, but I walk people through hospice care. People suffer terribly. This is a real group. I got a different perspective than sitting in a room with a bunch of addicted 20-year-olds that have lives that are in trouble, and those are all real serious things. But that doesn't apply to the patients that I'm talking about. They have cachexia, chronic malnutrition states, autonomic neuropathy conditions, chronic pain. I have 5 to 10 of them, probably 15 patients a week that I see sprinkled among more cheerful patients. And I have to be somebody for these people. I have to talk to them. I have to wear a lot of hats as a primary care doctor, right? Police officer, judge, friend, whatever, confidant, parent, every other role. But one of them is just to be a doctor and talk to people that have tried so many things and they're miserable. Now, there are these people out there. Now, what should I tell them? Okay, you know what? I'm sorry you're vomiting all the time and you're wasting away. I don't know if marijuana would help you or not, but you know what? I can't tell you to use it because it's a crime. So you know what? Ask the kid down the block to try it. Do I say that? No. I have to protect my DEA license, but that's a perspective that affects my judgment.
I would just say that I think that if the law were written narrowly and focused and airtight, that those who are dying, who are cachectic, and who are in that dire a situation, and if it was airtight, I think a lot more people would support it. But it's loose.
Thank you for caring for the